Too cloud. So this is just some basic anatomy. So going back to your A&P lectures, so anatomy for the penis. So this one shows some of the structures. We have our corpus spongiosum, our corpus cavernosum, urethra. We have the seminal vesicles, which produce the sperm. So this is actually within the testicles themselves. Then travels through the prostate gland, where the prostate secretes prostaglandins. Continues to pass through the prostate gland, where it meets up. Where the Copper's gland or the bulbourethral gland also secretes secretions that aid in the process during ejaculation to help protect the sperm. This continues through and passes through the urethra. So when we're talking about penile anatomy, we have areas of spongy tissue, and we're going to talk specifically about arterial blood supply and venous drainage as it pertains to ultrasound. So there's 3 columns of spongy tissue. Each is encased by a dense fiber sheath called the tunica, I can never pronounce this one, albuginea. We have the corpus cavernosum. So these are the paired layers of the spongy tissue that lie parallel on the dorsal side of the penis. It's the main part of the penis. Contains multiple synoid spaces or sinusoidal spaces, and expand and fill with blood during an erection. Then we also have the corpus spongiosum. This is on the ventral side of the penis, and this surrounds the urethra. The distal end broadens to form the glans penis. So this is just a cross-sectional slice. So you have your 2 corpus cavernosums, the 2 areas of the spongy tissue, and these contain the arterial blood supply. And then within that corpus spongiosum, we have the urethra, and this also contains some of the venous drainage as well. So with arterial blood supply, so it's the main source for arterial blood supply is going to be from the internal iliac artery. This travels through the internal pudendal artery, which then runs into the penile artery. We have the dorsal penile artery. This supplies blood flow to the lateral and deep. Has drainage. The dorsal artery is drained by the deep dorsal vein. The dorsal artery supplies blood flow to the glans penis and the corpus spongiosum, as well as the skin. And then we have the cavernosal artery. So this is going to be in that corpus cavernosum. This travels centrally within the corpus cavernosum, and this supplies blood to those cavernosal synoids. So these are the areas of the spongy tissue that are going to fill up with blood and create the erection. This is via that helicine arteries. The urethral artery supplies the corpus spongiosum and the urethral tissue. The bulbar artery is feeding the urethral bulb and the bulbourethral gland. So this is a image of the cavernosal artery. So this is going to be within that corpus cavernosum. And then we have the small helicine branches coming off of that cavernosal artery. So this is a midline along the Corpus Cavernosum. Small helical branches coming off. We have blood flow coming down the Cavernosal Artery. We got small branches, these halicine branches coming off, and these are what fill those sinoids that cause the penis to become engorged with blood. We do have the potential for shunting of blood from the penis during exercise when there's insufficiency in the internal iliac or femoral arteries. So if we have blood flow going in, we also have to have drainage of the tissue as well. So blood flow is going to exit those sinoids, or those the spongy tissue where the blood flow is collecting from the artery flow, empties into emissary veins, which drains into the circumflex veins, and this drains the corpora cavernosa, or that corpus cavernosum. We also have the deep dorsal vein, as well as the penile veins. The penile veins drain the proximal portion of the corpora cavernosa and joins the urethral veins. The urethral veins drain the corpus spongiosum and join the penile vein. So these all connect and then eventually join back into the pudendal vein, and that pudendal vein eventually dumps or drains into the iliac vein, internal iliac vein. We do have superficial drainage of the skin and the subcutaneous tissues, and this is done by the superficial dorsal vein. You can see over here is superficial dorsal vein. Deeper, we have the deep dorsal vein. So when we're performing the ultrasound, similar in a position where we position the patient for doing a testicular ultrasound exam. So the ventral side of the penis is going to be up. So we see the corpus spongiosum appearing anterior, and then the corpus cavernosum is going to appear posterior. So with normal erectile function, we have increase in the parasympathetic nervous activity. This leads to the smooth muscle walls of the cavernosal sinoids to relax and lower resistance. So that lower resistance allows for those sinoids to fill and become engorged with blood. So we have lower, now a drop in that resistance within that tissue, which allows for increased arterial blood flow to enter into those sinoids. The cavernosal arteries dilate. The sinusoids fill with blood, and the corpus cavernosa expand and become rigid. Important part of this also is that draining veins become occluded. So we have blood flow entering into the penis, filling those sinusoids, which expand and fill with blood, and we don't have drainage of those sinoids. So those draining veins become occluded, so the blood flow remains within that tissue, and that's what is why the erection becomes maintained. So this is just kind of a cross-sectional anatomy slice of the corpus cavernosum in a flaccid versus an erect state. So these are those sinusoids that are, empty with blood, and then during erection they become engorged and filled with blood. So requirements for normal erectile function. Patient has to have normal physiologic health, so they have to be in good health. Normal endocrine balance. So issues like with testosterone levels can affect erectile function. Intact innervations to the penis. So the nerve innervations that go to the penis have to maintain or be intact. So any disruption in that parasympathetic nervous system will affect erectile function. Normal cavernosal sinusoids. Patient must have adequate arterial blood supply. So if there's stenotic lesion, in the internal iliac artery, and this patient's not able to get adequate blood supply, to the penis, that will affect erectile function. It could even be something like poor cardiac output. Patient's got a weak heart and they're not getting adequate blood supply. And the patient also has to have normal venous occlusion response with erection. So if those veins don't occlude and the penis is continually draining blood out, they're not going to be able to hold and maintain an erection. So that condition of unable to achieve erection or maintain erection is called impotence. So complete impotence is the inability of the male patient to achieve an erection. They can have incomplete impotence. This is the inability of the male patient to maintain the erection. There's also a condition called organic impotence. So this is physiologic abnormalities that cause impotence. So it can be arteriogenic, an issue with the arteries, venous incompetence. So you can have, leaking of that venous drainage. So we want complete occlusion of those veins. This would be incidences where we have incompetence in that system, or Piranhas Disease, or it could be a psychologic impotence. So there is a psychological component to erectile dysfunction as well. So these are just a breakdown of causes of male impotence. So some of the things that stand out: diabetes. So that would affect that arterial blood flow, that arterial supply to the penis. Vasculogenic. So that'd be other vascular issues, including that venous drainage. Psychologic, neurologic, potentially be malignancy. Could be, again, endocrine issues, so low levels of testosterone, trauma, and then other. You can see a large portion of that is going to be vascular in nature, or potentially have vascular causes to it. So ultrasound Doppler evaluation of the penis. So this can be done to determine if impotence is due to vascular insufficiency. We're going to use a high frequency linear transducer, so 7 megahertz or greater. And we want a machine capable of detecting slow flow. So we're going to obtain consent and history. And we're going to image a non-erect penis and then an erect penis. So this is going to be the transducer position for Doppler examination of the Cavernosal Artery. So we're going to come just lateral on each side of that Corpus Spongiosum. So remember, the patient's going to be lying supine. The penis is going to be positioned up along the patient's abdomen and held into position. We're going to image. Remember, there's going to be 2 arteries that we have to image. So we have a Cavernosal artery on each side. It's going to be a right and a left. Now we're going to obtain longitudinal and transverse images. We're going to note areas of increased echogenicity. Sorry. We're going to measure diameter of the cavernosal arteries and record Doppler signals for the cavernosal arteries. So this is a transverse view of the penis demonstrating two symmetric corpus cavernosa. One and then two, they look symmetric in size. So we label them right and left, corpus cavernosum. And ventrally, we see the corpus spongiosum. So this is a image for the cavernosal artery in a non-erect penis. Longitudinal view of the corpus cavernosum demonstrating the cavernosal artery within it, within the sinusoidal tissue. The walls of the cavernosal artery appear echogenic. So here we see that cavernosal artery running in sagittal view. And we'd expect to see those Halicine arteries branching off of that. So in a flaccid state, a non-erect state, the cavernosal artery demonstrates a high resistant flow pattern with low peak systolic velocities. So we have a high resistant waveform in the flaccid state with low peak systolic velocity, so low velocity, high resistant. So the velocities usually are going to be are usually greater than 13 centimeters per second. We usually have absent or reverse diastolic flow. And there's no flow in the deep dorsal vein. So this is a picture showing sinusoidal scarring. So this is within one of the corpus cavernosa. We see an area that appears echogenic. So this transverse image demonstrates echogenic plaque in the midline extending into both corpus cavernosa. So this is another image showing that scarring. So the scarring appears as echogenic areas within that corpus cavernosa. So these are echogenic plaques that have developed. So Piranhas disease, this is a transverse view of the penis demonstrating a bright echogenic calcified plaque with shadowing. So we can see this very bright echogenic area. We get a little bit of posterior shadowing. In this longitudinal view, we can see a little bit better some of that posterior shadowing and that calcified plaque. So this is due to chronic inflammation of the tunica albuminea. I can't pronounce it. So it's a connective tissue disorder involving growth of fibrous plaques in the soft tissue, affecting 5% of males. Specifically, scar tissue forms in the tunica albuminea. The thick sheath of tissue surrounding the corpus cavernosa causes pain, abnormal curvature, and erectile dysfunction. Can lead to indentation, loss of girth, and shortening of the penis. So there's this fiber sheath that encapsulates the corpus cavernosa, as well as the corpus spongiosum. So that tunica albuginea, I can't pronounce, comes calcified. So we see the calcification here. So this would be a transverse view. And then when we turn it sagittal, it elongates. So we have an area of calcification there. So that's due to calcified plaque buildup and fibrosis of that layer. So we have Inter-Cavernosal Injections. So this is a direct injection into one of corpus cavernosum using a small gauge needle into the the second third of the dorsal side, dorsal 2/3 of the shaft. We inject a vasodilation agent to induce erection, causing sinusoidal smooth muscles to relax, and dilatation of the cavernosal arteries. Single injection acts on both corpus cavernosa via multiple communications across the intercavernosal septum. A tourniquet may be placed at the base of the penis to prolong the local effects. Graceful and Doppler evaluation for the erect penis now. So we note changes in the corpora cavernosa. We measure again now the diameters of the cavernosal arteries, because remember, after we do that injection, we should see an enlargement or dilatation of those arteries. Doppler assessment should start 2 to 3 minutes after the injection. Continue Doppler assessment post-injection at various time increments until peak systolic velocities have plateaued. And we assess flow within that deep dorsal vein. So transverse view shows enlarged corpus cavernosa with a speckled appearance due to blood-filled sinusoids. So we should see enlargement of this tissue. A longitudinal view of the right corpus cavernosum demonstrates the cavernosal artery with the cursor. So that's up here. So you can see the walls of that artery are very echogenic. That's easier to visualize. So we're going to measure diameter now for that vessel. So we should see dilatation of that artery. So this is a cross-sectional view showing the differences between a non-erect and erect penis. We see now just dilatation of the sinoids causing dilatation of the corpus cavernosum. Appears more heterogeneous in appearance. So after injection of that vasodilator, so in this case they used papaverine. The longitudinal image shows the cavernosal artery that demonstrates high velocities now and low resistant flow. So we went from low velocity, high resistant to high velocity, low resistant. So we now have low resistant flow with a high diastolic component. and we have increased peak systolic velocities. So now we have, in this case, we're measuring peak systolic velocities about 42 centimeters per second. So cavernosal artery after full erection is achieved. At this point, we now transition into a high resistant waveform with a sharp systolic peak. So we still have those fast velocities. And now we have absent diastolic flow. So as that penis is becoming engorged after the injection, we have the vessels become dilated. The tissue becomes dilated. It's filling with blood. We have low resistant blood flow now because it's a low resistant vascular bed because of that vasodilatation. We have increased velocities. At full erection, at peak erection, we then abruptly change to a high resistant waveform now with a sharp systolic peak. So we still have elevated peak systolic velocities, but at this point now we have absent diastolic flow. So we have an absent end to diastolic flow. We still have a high resistant waveform with a sharp systolic peak. And we can even at this point have reversal of diastolic flow. So still a very high resistant waveform with elevated velocities. So this just kind of shows the progression following injection. So we have ejection, 2-3 minutes afterwards. We have high velocities, low resistance. Penis is continuing to fill with blood. The sinusoids are continuing to fill. The intrapenile pressures are increasing. And as those pressures increase, we eventually wind up with less and less diastolic flow. So we reach that point of full erection. We have no diastolic flow, but still increased velocities within that cavernosal artery. And then we can actually reach a point where we have reversal of diastolic flow. So this would be that full stiffness or full rigidity. And eventually we can wind up with actually dampened flow. So systolic flows become dampened. So if there's arterial insufficiency, so if there's not adequate arterial blood supply getting to that tissue, the maximum cavernosal peak systolic velocities are going to be lower. The greater this, so the lower those velocities, the greater the severity of arterial disease. So normally we should have peak systolic velocities greater than 30 centimeters per second. If the velocities are between 25 and 30 centimeters per second, this could signify mild to moderate arterial insufficiency. If those peak systolic velocities are less than 25 centimeters per second, this would be indicative of severe arterial insufficiency. So there's very poor blood supply now getting to that tissue. A discrepancy of max velocities between the right and left side of greater than 10 centimeters per second could indicate some degree of arterial insufficiency on that particular side. So this is an example showing arterial insufficiency. So this is that cavernosal artery waveform with arterial insufficiency. So even though the waveform looks like what you'd expect with low resistance, our peak systolic velocities are very low. So this would be indicative of arterial insufficiency. So this is normal versus abnormal waveforms after papaverine injection. Normal low resistant waveforms with the peak systolic velocities of 39. So this would be normal. And then abnormal with abnormally low peak systolic velocities. Basically, the main takeaway from this when we're assessing for arterial insufficiency is we're looking at those peak systolic velocities. So decreased peak systolic velocities are going to be indicative of arterial insufficiency. So not enough blood flow getting to that tissue. So anything, so over 30 is normal, less than 30 is considered abnormal. So use 30 centimeters per second as your number to memorize as your cutoff. Recognize this picture. I think it shows up somewhere. Intent. So your cavernosal artery with those halocene branches coming off. So those branches that would actually bring the blood to the sinusoids within that tissue. You can see them coming off both sides. The halocene branches. So the other side of the equation, if it's not arterial insufficiency or poor arterial blood supply to the penis, it could be an issue with venous incompetence. So venous incompetence can fail to generate adequate, can be a cause of failure to generate adequate erection despite normal cavernosal arterial waveforms. So with this, we're going to assess flow in the dorsal vein. So some of the things that can potentially indicate venous incompetence would be persistent high diastolic flow in the cavernosal artery with diastolic flow greater than 5 centimeters per second without evidence of dorsal venous flow. Suggests venous leakage. So venous incompetence can be assessed only if arterial function is normal. So if we have normal arterial waveforms, we get elevated velocities. We don't see that gradual change as that patient is obtaining, peak erection or full erection. If we don't see those resistive indices starting to come down and it maintains a low resistant waveform with high diastolic flow, then that issue is going to be an issue with venous incompetence. So we should look for a normal, that transition from low resistant to high resistant. If we don't see that and it maintains a low resistant waveform with high diastolic flow, that issue is then venous incompetence. So this is a picture showing a competent normal venous waveform. So we have high resistance with absence of diastolic flow. So this is associated with venous occlusion. So we want that venous occlusion. So this is an example if after we do the injection and the patients may achieve that full erection, and we still have that increased diastolic flow. So we still have a low resistant waveform at this point. So this would be indicative of venous incompetence. So we're getting leakage of blood flow back through the veins. So this is now a sagittal view of, here we're imaging the corpus cavernosum and the dorsal vein running posterior to it. Longitudinal colored view shows flow in the dorsal vein. Doppler waveform demonstrates flow in the dorsal vein. And the imaging is done from the ventral aspect of the penis. Just some limitations. Patients are difficult or impossible to study. Some patients may not be able to undergo the injection component of it. I don't think I would. Someone came at me with a needle like that. Patients with psychologic impotence. So this, if they have a psychological component that leads to their impotence, that's, they're going to have a normal vascular study. Patients with anatomical variants. And then venous incompetence can be assessed by Doppler only if arterial function is normal. So if they have poor arterial function, they're going to have poor venous function as well. So we can't get an accurate assessment of venous incompetence if they have abnormal arterial function. So there's a condition called Preemptivism. This is a persistently erect or engorged penis. We can have low flow Preemptivism. This results from occlusion of the draining vein from the penis, trapping blood in the sinusoids. And this can eventually lead to thrombosis. It can also lead to ischemia of the corpus cavernosa and cavernosal scarring, associated with diseases complicated by a hypercoagulable state. With this condition, there's minimal flow seen in the cavernosal artery with high resistant flow. The sinusoids may appear hypoechoic if thrombosis has occurred. So this condition, essentially, it occludes or blocks the draining veins from the penis, and it traps that blood flow for an extended period of time within that sinusoids. And you now wind up with a condition where we have stasis of blood within the sinusoids. And this could lead to thrombosis of that blood within the sinusoids. So we have ischemia of that tissue. We can wind up with scarring of that tissue. And because there's actually thrombosis in those sinusoids, it'll appear as hypoechoic areas or hypoechoic lesions of thrombosis. We can have high flow Preemptivism. This results from trauma with arterial rupture, leading to intercavernosal or arteriovenous shunting, or misuse of medication that causes prolonged sinusoid muscle relaxation. So this would be cases where you hear, patient takes Viagra or, those erectile medications, and their erection won't go down. So this is actually a medical emergency that they should be seeking treatment for. In this case, we have high flow in the cavernosal arteries and the helical branches. And there's dilated cavernosal sinusoids that appear anechoic. So basically, we've created an arteriovenous fistula due to rupture of those vessels, those intercavernosal vessels. So it could be from trauma or that misuse of erectile dysfunction medications. So we get rupture of those smaller vessels that lead to arteriovenous shunting. So we basically created an arteriovenous fistula or arteriovenous malformation within those tissues. And now we have blood flow shunting directly into the venous system that leads to high flow. We have high flow in the cavernosal arteries and the helical branches, and dilatation of those cavernosal sinoids. There is non-imaging evaluation of the penis as well. So this involves using our PVR SLP machine. So we do basically penile plethysmography. So this may indicate pelvic steel or ipsilateral arterial occlusive disease. So we have the patient supine with appropriate draping, cuffs on the upper arms, ankles to measure ankle brachial index. We use the continuous wave probe, so our little pencil probe, and we use volume plethysmography. So the cuff size we use is a small 2.5 centimeter cuff, a penile cuff. And we do this to obtain a plethysmography waveforms. So we're going to get our little PVR waveforms of volume recordings. Bless you. And we also obtain penile pressures from multiple sites with pressure cuff around 45 millimeters of mercury to calculate a penile brachial index. We perform leg flexion exercises if the pelvic steel is suspected. So we're going to try and exercise the leg to create a steel syndrome where we would require increased blood demand to the extremity. It can be done lying and do bicycle leg motion. So we have them kind of do like bicycle leg motions in the air. We measure pre and post exercise pressures. And we calculate pre and post exercise PVIs. So similar to our ankle brachial index, we use the highest penile systolic pressure divided by the higher of the two brachial pressures. So a normal PVI is going to be 0.75. Same as with an ankle brachial pressure. As those pressures go down, they're more indicative of disease. So a lower PVI between 0.65 and 0.74 would be marginal or borderline. Less than 0.65 would indicate vasculogenic impedance. Post-exercise, we have a drop in pressure similar to our exercise PVR. So with our exercise PVR, if we see a decrease in the ABI, that indicates, arterial insufficiency. So same thing here. If we have a drop greater than 0.5 millimeters of mercury, 0.15 millimeters of mercury, this indicates insufficiency and indicates a pelvic steel. So blood flow is being siphoned away from the penis and brought to the extremities due to insufficiency in those muscles in the extremities. So we can diagnose a pelvic steel. If we have post-exercise, a drop in that penile brachial index of greater than 0.15 millimeters of mercury. So we can also obtain Doppler waveforms. So we're going to Doppler the bilateral cavernosal arteries to look for signs of stenosis. And then we can also interpret the plethysmography waveforms. So similar to our lower extremity PVR waveforms, normal, we have a sharp systolic peak with a prominent dichrotic notch. And as we get more disease, we lose that dichrotic notch first. That's the first thing to go. First sign of mildly abnormal. Moderate, we get a flattened systolic peak, absent dichrotic notch, and then severely abnormal, we have the very low amplitude waveforms, or potentially absent. So it's very similar to our lower extremity PVR of the penile plethysmography waveforms. Normal, mild, moderate disease, severe disease. So we just get a dampening of that waveform, loss of dichrotic notch, rounding, and then a very low amplitude waveform when it's severe disease. Again, just a picture showing normal versus abnormal. Normal waveform versus abnormal waveform, and abnormally low pressures and a normal penis to brachial index. So just to recap, 30 centimeters per second is going to be our magic number for peak systolic velocity. Initially, right after injection, we should see low resistant flow, which slowly transitions to high resistant flow. So this is going to be our normal response. As the penis becomes engorged, pressures start going up. As those sinusoids fill with blood, we actually wind up at the point where we can get some flow reversal. So this is a normal response. If it's arterial insufficiency, an arterial issue, we're not going to have those elevated peak systolic velocities. So we'll have peak systolic velocities that are going to be less than 30. If it's an issue with venous flow, venous incompetence, we're not going to have this transition as the penis becomes engorged, going from low resistant to high resistant. It's just going to maintain a low resistant waveform throughout. So throughout the period, as that penis is becoming engorged, if it's a venous issue, we'll continue with a low resistant waveform. So that's how we're able to tell if it's a venous issue versus arterial. And then for plethysmography, numbers. So for numbers for plethysmography, normal, it's going to be greater than 0.75, and then less than 0.65 is considered vasculogenic impedance. And then we do exercise to assess for the potential for pelvic steel. Trying to think of the main points that probably show up on your registry. Any questions about any of this?
Have you ever done one of these?
We did a plethysmography. I've never done an ultrasound. We did a plethysmography once in like 10 years. We did once. In vascular lab, peripheral vascular lab. Yeah.
When I was like was like talking about ordering one, but then they like got out of it.
I would imagine this injection one is probably done maybe at like a urologist's office.
Yes, it's like you're
Yeah.
injecting.
I'm sorry?
So you inject to create the erection.
Create the erection, yeah.
I feel like coming at it with a needle.
Yeah. I'm dropping with the cup.
Yeah, don't look.
Like you can't just like give them
Yeah, I was wondering that, like, as they are,
like
giving
here,
me.
let's try this first. And then there's a second option. So that, like,
Yeah.
you know?
You have the choice of this.
Yeah,
Or
so
this.
that's the one.
Yeah, that's just crazy.
Like, no.
I would never want to do it. Everybody wants this cup more. Yeah.
Well, don't overinflate. Like you're only going to 45.
We have a student today, they're gonna.
Yeah.
We always do.
Exactly.
We feel like everybody.
Oh, brother. All right, next. Would they kick you out of it?
The lady didn't want students.
Oh, for pelvic?
She was like, "Why have student with you? Why?" She was like, "No." I'm like, "Oh, okay, I'll just go sit down."
Oh,
Cool.
other.
Yeah, so now for something completely different. Other vascular tests. So some of this stuff we've actually seen before and we've talked a little bit about. So angiography. So basically think of angiography as using X-ray to image the vessels. So with angiography, we're going to administer contrast. And now we're able to do angiography in real time. So we can actually image contrast as it fills the vessels. And we're looking basically for filling defects. It could be used not only in angiography to assess arteries, we can do venography. So I'm sorry, we can do arteriography or venography. So angiography is looking at blood vessels themselves. We can do assess arteries, assess veins. We also have interventional procedures. So when we're talking about basic angiography, it's typically X-ray. We can also do CT guided or computer tomographic angiography using a CT machine. We can do angiography using MRI. And then we can also use nuclear medicine imaging as well. So there's a couple different modalities that we have options for. And each one has its benefits and drawbacks. Again, so angiography, so this is using X-ray filming of blood vessels after injection of a contrast medium. So there's a process called digital subtraction angiography. So this actually allows us to perform angiography in real time. So it's real-time digital video processing to detect small amounts of contrast medium as it's injected to the vein or artery, or it's injected into the vein to study the blood vessels. So the computer subtracts an earlier image from a later image and displays the difference on the fluoroscopy monitor. So basically the X-ray machine has an image prior to contrast arriving and then images as contrast is arriving. So you're able to kind of get like a real-time image of almost like a cine loop of that contrast as it courses through the vessel. So angiography, we use it for evaluating stenotic lesions. So it's good for imaging vessels where we can't see with ultrasound. So think of it like, you know, arteries in the mesenteric, in the abdomen. It's also used during interventional procedures, as well as for follow-up after vascular surgeries. With these procedures, they're guided using apparatus called a guide wire. So these guide wires, they allow for safe introduction of catheters into vessels. The guide wires allow radiologists to position catheters within the vessel network. Once the catheter is in place, guide wires are made of stainless steel, and they contain a stiff inner wire tapered at the tip to a soft tip. Another fine core wire that joins to both ends of the guide wire and prevents the loss of sections of the wire should it break. The trailing end is stiff to allow for maneuverability along the length of the guide wire. Conventionally, it's about 145 centimeters long, and the catheter overlaying it is usually about 100 centimeters long. Wires are categorized by length, configuration of the tip, and stiffness. Example, a J-tip guide wire is used for atherosclerotic vessels. The J-tip deflects off the edges of plaque and prevents dissection of the vessel wall. So these are some techniques for inserting catheters. So these are all done under sterile conditions. So in this case, Selinger needle is an 18 gauge hollow needle with a stylet. Once the Selinger needle is inserted, the pulsating arterial blood flow returns, the stylet is removed, and a guide wire is inserted into the artery. With the guide wire in the vessel, the Selinger needle is removed and the catheter is threaded into the guide wire. So we insert the needle, get into the blood vessel. Through that needle, we insert the guide wire, and then over that guide wire, the catheter is inserted. So this is basically the procedure that we do a catheterization for a vessel. So we have a couple different types of catheters that could be inserted into the vessels. It just kind of goes through some of the different catheters. Yeah. So these are a couple different types of catheters that you might encounter. S1, Simmons, C2, pigtail, Bernstein. You guys familiar with the book, The Berenstain Bears? Fun fact, look at the title of the book, Berenstain. It's not Steen at the end, it's Stain. Sorry, a little aside. So this just shows some of the different uses for some of the catheters. So that Simmons is highly curved approach for sharply angled vessels such as the celiac axis. The C2 has an angled tip joined to a gently curve that's used for introduction into renal and mesenteric arteries. Pigtail has side holes for injecting contrast medium into a compact bolus. The jet effect is minimized with a curved pigtail to prevent vessel injury. Catheter is usually flushed with heparinized saline after the guide wire is removed to prevent clotting. So contrast media and patient preparation. So contrast media is injected with radiopaque contrast media. In the past, ionic compounds have been used. Non-ionic contrast media has now been introduced, which causes fewer physiologic problems, and fewer adverse reactions. Patient preparation. So before any of these procedures are done, we have to obtain informed consent. So part of that, is explaining the procedure, any complications that may arise. We obtain patient medical history, surgical history, and allergies. So I want to make sure they're not allergic to any of these contrast agents. After procedure, we use minimal compression. Use manual compression or a fibrous plug on the puncture site. So after catheterization, you'll often see the nurses in the cath lab holding pressure over that arterial site in order to close off that vessel, prevent pseudo-aneurysm. After the catheterization, patients must remain immobile for at least 4 hours while vital signs are frequently monitored and the puncture site is inspected. So we're looking for any leakage, drainage, swelling of the puncture site, abnormal skin color changes. So the main thing or the main complication that for us as sonographers that we'd worry about for patients that are post-cath would be a pseudo-aneurysm. So that's the main thing that we'd be looking for, after a patient undergoes a catheterization. And remember, if they want to rule out pseudo-aneurysm, there can't be any dressings over that puncture site. So we have to, before the patient comes down, ask the nurse, do they have any dressings over the site where they had the catheterization? And if they do, can you please remove those dressings? You don't want to be in the habit of removing dressings in your department. You never know. The patient might all of a sudden start bleeding on you as you pull off that bandage, squirting blood. You do not want that. So have the nurse remove the dressings prior to the patient coming, or otherwise you can't really do your full evaluation for pseudo-aneurysm. So this is an angio interventional suite. So the x-ray that they do use for these angiograms, usually called a C-arm. I've seen portable C-arms. So it's kind of like a C there, where you have a transmitter and a receiver on on one side. This is just a picture showing an abdominal angiogram. So these are the images that they get. So using that digital subtraction angiography, they can actually do a real time as the contrast is being administered, and you see the contrast as it spreads through the renal arteries. You can actually see here the catheter tip. So the guy, that catheter within the vessel itself. So there's different interventional procedures, vascular interventional procedures that can potentially be performed. So there's percutaneous transluminal angioplasty, atherectomies, laser angioplasty, placement of vascular stents, thrombolysis, placement of thrombus filters, embolizations, and angioscopy. So angioplasty or balloon angioplasty. So this is used to help reperfuse vessels in areas where we have plaque and stenosis buildup, where we get arterial insufficiency. So with this, we have poor flow going through an area that's stenotic. The catheter with the balloon on the end of it is inserted into that area where we have the narrowing. The balloon is inflated repeatedly. So inflated 2 to 10 times, and that inflation kind of presses that plaque up against the luminal wall and opens up that channel now and helps to improve blood flow through that stenotic lesion. So this is balloon angioplasty. Again, so that's percutaneous transluminal angioplasty. Seeks to improve blood flow and supply by widening the vessel lumen using balloon catheter. This is used for discrete or focal areas of stenosis that are easily treatable. So we can also do an atherectomy. So this is actually removing of atherosclerotic plaque with directional atherectomy. A catheter with a shaving device shaves the blockages and stores the plaque safely in the tip of the catheter and removes it from the artery. So you don't want to go in there just kind of scraping out plaque, because that shavings, that plaque could potentially become emboli, and that emboli will travel, into the distal arteries and potentially occlude smaller, more distal arteries. So you want to ensure that that plaque is safely stored within that catheter tip. There's rotational atherectomy or rotational ablation. So a catheter with a high-speed diamond tip drill is spun, and the artery resulting in a very small particles being removed from the blockage. There's also a transluminal extraction catheter. So this is a specially designed catheter that continuously cuts the blockage from the artery or bypass graft while removing the particles by vacuum. So this can also be done using a laser catheter. So a catheter containing fibers that carry laser energy is used to precisely dissolve blockages. Ultrasound guidance can be used with laser atherectomy. So we can, another vascular intervention could be placement of vascular stents. So stents are a metallic device placed within a newly opened vessel to keep it patent. Patients generally need to take antiplatelet medication or anticoagulation to prevent blood clots from forming on the stent. There are two different types. We have a self-expanding stent or a balloon expanding stent. So basically these stents are also placed on the end of the catheter and then positioned in the area where we have the vessel narrowing. If it's a balloon stent, the balloon is inflated to place the stent in place. If it's a self-expanding stent, the stent is then released and expands on its own. It's used to open up areas where we have clogged arteries. We can also have embolectomy. So we have, an arterial embolus that's entered into the artery. So just remember, our most likely source for arterial emboli is going to be from the heart or cardiac source. So in this case, the catheter is then pushed through that embolus, past it. The balloon is inflated, and then the catheter is withdrawn or pulled back to pull back that embolus and remove it from the vessel. So think embolus, think of a soft blood clot. So this has to be a soft embolus. So think of an arterial clot. It's pushed through, and balloon is inflated and then withdrawn and pulling the clot with it. Can also use another procedure would be thrombolysis. So with thrombolysis, that ending lysis is destruction or breaking down. So in this case, we're positioning a catheter at the site of occlusion and administering a thrombolytic agent. So some sort of medication that's actually going to break down that clot or dissolve that clot. We can use interventional radiology to place thrombus filters. So the most common one being an IVC filter. We can also have procedures where we're doing embolization. So with this, this procedure introduces a substance, either a mechanical device or a chemical material to produce a temporary or permanent occlusion of a vessel. So you think about that, like why would we potentially want to occlude a vessel? And some indications would be to control bleeding. So if this patient has a GI bleed, or even potentially a bleed within the brain if they're having a hemorrhagic stroke. We want to stop that bleeding, so we're going to embolize or cauterize that vessel to control that bleeding. So it's to reduce blood. You can also use it to reduce blood supply to tumors or organs, or with circulatory malformation. So if the patient has an arteriovenous malformation that we know about, we want to cauterize or close off that feeding artery to close off that arteriovenous malformation. So it can be used as a preoperative procedure to stem blood flow to a particular site. Another procedure that is done in the interventional lab would be an angioscopy. So this is direct visualization of the inner vessel surface by means of a miniature endoscopic or angioscopic camera into the vessel. So it has high resolution optics and a tiny video camera. Areas to be inspected by angioscopy. In the areas inspected by angioscopy, we inject saline irrigation and proximal balloon catheter occlusion are used. Since light waves cannot transverse the blood. The indications for angioscopy are mainly surgical and interventional or an interventional procedure. It's largely replaced by more economic and easier to handle techniques like intravascular ultrasound. So this is intravascular ultrasound now. So this is an invasive procedure where a miniature sound probe or transducer on the tip of a catheter is threaded through the arteries, and we're able to get high frequency sound waves that produce detailed images of the inner walls of the arteries. So this aids in the selection and sizing of stents and balloons, and offers assurance that the stent has been properly deployed. So it's a little ultrasound probe, a little transducer on the tip of a catheter that gets inserted into the vessel itself, and we can actually get ultrasound images from inside the vessel. Bless you. So just to kind of quickly go through these, we can also have angiography using CT. So this is kind of similar to our X-ray angiography, but in this case, we're getting a three-dimensional image. So this is X-ray is basically CT is basically a fancy X-ray taken from. It's an X-ray that spins around the patient and takes multiple X-ray images and creates a three-dimensional cross-sectional image. I'm sorry, two-dimensional cross-sectional image of the structures that we're imaging. CTA is best seen with contrast and allows for relatively accurate measurements of residual luminal diameter. So some examples of some CT images. So these are images that we're familiar with. And with the administration of contrast, we're looking for, again, filling defects within the vessels themselves. So CT is very good, particularly for looking at pulmonary vasculature, so looking to rule out pulmonary embolism. It's also good for looking at mesenteric vessels as well. So with CT, it's done in a spiral or helical motion where that X-ray imaging plate is spun around the patient while they're lying on the table. So the X-ray machine rotates continuously around the body in a spiral patch to make cross-sectional pictures of the body. So this is again another spiral image of CT. So the arrows are showing areas where we don't have opacification or filling of those vessels of contrast. So those indicate areas where there's blockages. In this case, it's in the pulmonary arteries, showing pulmonary embolism or emboli within the pulmonary vessels. So when you hear that term opacification, that's a filling of the vessel with contrast. And then on the right, it shows a femoral artery after AVF and a stent graft insertion showing a pseudo-aneurysm. So we have a large area that's filled here with contrast. So we can also use an MRI machine to perform imaging for vessels. So this is called a magnetic resonance angiogram, or an MRA. So it can be non-invasive or invasive with the introduction of contrast. It's based on magnetism and radio frequencies applied according to principles of nuclear physics and quantum mechanics. They use the spin magnetization of portions of blood to visualize flowing blood. And we can use it to evaluate blood flow and identify blockages. The only caveat to this, vessels running parallel to the imaging plane may appear narrowed. This is an MRA image for an abdominal aortic aneurysm. She didn't mention it here, but some drawbacks for MRA. As you know, MRIs take a long time to perform. So an MRI is a much longer exam than a CT. CT, you're in and out, it's fast, boom, boom, you get your information. An MR takes a much longer period of time, and it's also very sensitive to motion. So if patients are claustrophobic, they can't stay still. MR is not a good choice. If you want to rule out stroke very fast, you're not going to do an MR. You're going to go to a CTA to evaluate, patients that you're concerned about stroke, that you need a fast answer. You could potentially do an MR once the patient's more stable. Also, with MR advantages, you don't have the nuclear component, the radiation. So you could potentially use an MRI with pregnant women. You just can't administer that contrast with pregnant women. And then the last option that we can potentially do is nuclear medicine imaging. So provides the earliest detection of abnormalities or disease. Uses small amounts of radiopharmaceuticals or tracers that are typically injected into the bloodstream, inhaled or swallowed. The radio tracer travels through the area being examined and emits gamma rays, which are detected by a special gamma camera. That gamma camera and a computer enhance the signals to form an image of abnormality or disease. Some examples of us using nuclear medicine would be to assess for GI bleeding, to detect areas of bleeding in the intestinal tract. We can use it to scan kidneys, to check blood flow through the kidneys. Big one would be your VQ scan, your ventilation quotient scan, to assess for potential for pulmonary embolism. Just an example showing GI bleed scan. And then this is a PET scan. This is a positron emission tomography. So Positron emission tomography provides qualitative information. So patients using radioactive tracers as they travel through the body collect collected by various organs targeted for examination. So it creates a functional images of blood flow and metabolism. And so we can assess for areas increased and decreased uptake of those radioactive tracers. So you may see now where they combine PET with a CT and what's called a PET CT. So they kind of overlay a CAT scan over this PET scan. So they can visualize the actual structures using also the PET functions to find areas of increase and decreased uptake and decrease and increase metabolism to spot areas of cancer with a CT overlaid. So you can see the actual anatomical structures very clearly with the set PET function over it. All right. You guys, any questions about some of these other procedures? Not really. For DMS, some other nuclear med procedures would be like your HIDA scan when you're looking at the gallbladder. That's one thing they like to do, the HIDA scans, checking for cystic duct for stones or CBD for stones, checking, assessing how the gallbladder contracts and drains the bile. Did I guys tell you the story about the radiologist that I had that made my patient cry? Because he told her, we're going to have to hide you in the basement. And he had a thick, heavy Indian accent. So he's like, well, I just want to let you know, we're going to have to do another test on you. We're going to probably keep you overnight. We're going to hide you in the basement. And, so don't worry. So she's like, what do you mean, like hide me in the basement? Yes, we're going to hide you in the basement. Because these tests are usually done like, in the basement of the hospital. So I was like, don't worry. I had to calm her down. So she got all scared.
Oh, kidnap her.
Yeah, we kidnap her and hide her in the basement. I know, I just want to go home. I have a family. Oh, Occam. His name was Occam. He's dear to my heart. Like I had to yeah, he was the nicest guy in the world, but his patient bedside matters. Like he was so innocent too. Like I remember one time he was trying to gain consent for a procedure, like what were we doing? Maybe like a pseudo injection or something like that. He's like, the dangers of this procedure is, is you could bleed a little, you could bleed a lot. So, there's always bleeding that could happen. So, how come we got to work on your lines here? That and we're going to send you for a CAT scan because what I see here on ultrasound, it's most likely hemangioma, but we want to make sure it's not cancer. I'm like, oh my God, Occam. You don't say cancer to patients. He got better by his fourth year, though. All right, so sonographic contrast agents. I was going through this PowerPoint. It's a little in depth. So I know. I know this is going to be cliff notes. So the goal of any contrast agent is to improve imaging. So we want to increase the ultrasound signal that's returned to the transducer. So these contrast agents will allow for increase of that return of signal and improve imaging qualities. They change specific properties of the organ with regard to the surrounding tissue. They increase the signal to noise ratio. In ultrasound, the use of air bubbles is used to increase the reflectivity and backscatter. So those air bubbles will increase reflectivity of that ultrasound beam and increase imaging properties. It's used to improve imaging of deep low-lying vessels, slow-moving blood, and visualization of small vessels. So vascular agents can be used to help outline vascular trees, so we can see potential collateral vessels, how the vessels branch out. This is done through IV injection. The vascular agents help enhance Doppler full flow signals as well. So we were able to get better spectral tracings. We're able to detect flow that we may not have necessarily been able to detect before. Contrast agents are tissue specific, and we have targeted agents depending on which tissues we're going for. So these contrast agents will help to help us to visualize targeted areas of plaque and thrombus. Again, it's used to improve detection of blood flow, particularly detection of slow flow, enhance the echogenicity of targeted tissues. Contrast agents can also be used as therapeutic agents. So this is more of a newer technology or use of contrast agents. So in this case with therapeutic agents, ultrasound energy causes cavitation or vibration of those microbubbles. And that cavitation, that energy of that excitation of those microbubbles delivers mechanical energy to the surface of the tissue and actually helps to break down plaque at a small microscopic level and helps allow reperfusion or improvement of blood flow to very small vessels. So this is actually something that my hospital in New York started doing where we would introduce these microbubble contrast agents, allow it to flow down to the extremity where the wound was, and we'd hold the ultrasound probe over that area as that contrast passed through those small vessels. The ultrasound excited those microbubbles, caused them to vibrate and move, and helped to actually break up some of the plaque in that area. I mean, we're not talking about large vessels, we're talking about the very small, like the arterioles and at the capillary level, like small microscopic plaque. And it helped increase perfusion to that tissue. So you'd actually be able to see increased perfusion to that tissue. It can also be delivered contrast to help treat a variety of abnormalities, including neointimal hypoplasia. So that just to refresh, neointimal hypoplasia, we see that as typically after patients who have carotid endarterectomies. So that intimal layer, as a response to the trauma of that endarterectomy, sometimes develops thickening. That's the hypoplasia component of it. And with neointimal hypoplasia, we see it typically post-op or post-procedure, usually about up to a month or two after procedure. We get all of a sudden narrowing of that vessel because that intimal wall has become thickened. So kind of tie neointimal hypoplasia to a post-procedural thickening of that intimal layer. So in this case, it was with the coronary artery in the heart, but we can also see it with the carotid arteries as well. So this is ultrasound-induced thrombolysis. So again, this is talking about that microparticles containing an encapsulated thrombolytic drug. So it can be coupled to site-specific substances. So that contrast agent has medication in it that is thrombolytic in nature. Those microbubbles, once the ultrasound is applied to it, they rupture, releasing the medication on the area that needs the plaque to be dissolved. So physical properties, clinical use. So for a contrast to be clinically useful, it has to be non-toxic. The particles have to be small enough to pass through the pulmonary capillary bed and able to excrete via the lungs, but large enough to reflect ultrasound signals. They have to be easily injectable. They have to be able to pass pulmonary circulation without being destroyed. Stable enough to provide multiple circulations or remain intact for a period of time, being able to scan. And they have to be uniform in size. With microbubbles, these are gas-filled liposomes. The shells provide stability, most commonly comprised of bilipid phospholayer entrapping a gas bubble within the interior. Contains a heavy gas such as sulfur hexafluoride or fluorocarbons that improved microbubble longevity. So this is an electron micrograph of bubbles. So these contrast agents, they're injected with a small bolus in the peripheral vein to provide several minutes of enhancement. Administered through slow flow IV infusion to provide prolonged enhancement. So popular one is the infusion of a contrast agent called Definity. So Definity is commonly used with echocardiograms, and it's been approved by the FDA. So these are a list of some FDA-approved contrast agents. So over here just lists some of the indications that they're used for. So left ventricular opacification, so filling that left ventricle with contrast in order to be able to see the borders of that, what are called endocardial borders, or that inner lining of the left ventricle. So Definity is going to be your most common one that's used in echocardiography today. Another contrast agent is Optison. These are some other contrast agents that are available and their intended uses. No one plans on doing ultrasound in China, Singapore, South Korea, Iceland. You know, you never know, right? European Union, EU.
I couldn't do that.
I'll move to Denmark. So and then Definity is the one that's, you know, it's definitely United States we use common. So there are some artifacts that are associated with the use of contrast agents. So you can potentially have shadowing that could develop. This is due to excessive backscatter. Blooming, so we get an overwhelming backscatter. So that's it'll appear that contrast is actually, you know, coming out of the vessel itself. So same thing if we have blooming in regular ultrasound, we can lower our color gain or increase our color scale to remove blooming. There could potentially be bubble noise. This is instability and bursting of bubbles or presence of large bubbles. We can wind up with spectral broadening when we're doing our pulse rate Doppler and elevation of peak systolic velocities. So not affecting PI or our velocity ratios. That's why your velocity ratio can sometimes become important. So that's pulsatility index or your velocity ratio. So also think of RI. So you can throw RI. So these artifacts, even though you have spectral broadening and elevation of that peak systolic velocity, it won't affect your RI because you'll also have increase in your end diastolic velocity as well. So that ratio will remain intact for an RI, resistive indice, or a pulsatility index. And it won't affect your velocity ratios if you're, going between two segments, because they'll both be elevated within both segments. So you have equal elevation, from segment to segment. So just an example of blooming artifact. So you see the contrast kind of overspilling the vessel walls. So this would be contrast administered to assess for renal artery stenosis. We have blooming. So it's a very, not a nice picture. So in this case, we maybe turn the gain down or increase the scale. As the contrast gets uptaked, this blooming will decrease. So several minutes later, the blooming resolves as contrast diminishes. And then the Doppler shows a high velocity jet of 245 centimeters per second. We may see within our spectral waveform bubble noise artifact. So these are these little echogenic spikes that we see within our spectral tracing. So this is just artifact. So the contrast may cause spectral broadening and as well as increase, be able to, may also exhibit increased velocities. So this is a patient prior to contrast. They measured peak systolic velocity of 39 centimeters per second. After contrast, we wind up with filling in of that spectral window, as well as demonstration of increased velocity, so an increase of 25% in this case. Contrast can also be used in harmonic imaging. So it's useful when conventional sonographic imaging is limited by motion artifact. We may not have enough penetration for obese patients if transmitted frequency is not low enough. So based on microbubbles-based contrast agents to resonate at a specific frequency once they are encountered by the ultrasound beam. So they transmit a specific frequency and receive at the same resonant frequency. So this is an example of conventional imaging versus harmonic imaging. So typically, conventional imaging transducer will send out a certain frequency, hits the tissue, gets resonated back at that same frequency. With harmonic imaging, you get a compounding of that frequency, and that harmonic frequency that comes back is at a higher frequency. So this is just harmonic versus non-harmonic imaging. We get a little bit better detail with our harmonic imaging because it's coming back at a higher frequency. So if you think back to physics, higher frequency improves both axial and lateral resolution. No, this is not going to appear on your boards. So this is a contrast-specific ultrasound image for the aorta and the right renal artery. So in this case, the arrows show echogenic plaque. The arrowhead is present near the ostium. So the arrow showing the renal artery, that's showing the plaque. So this picture here we show blood flow in a leg muscle using a low mechanical index and a contrast specific imaging. With color Doppler imaging, the mechanical index of 1.9 is used to rupture the microbubbles. And then C&D, so progressive refill of contrast containing blood flow is enhanced using a low mechanical index for 5 seconds, and then at 19 seconds. So with this imaging, we get an image, we apply the color Doppler to rupture the rupture those microbubbles to release the contrast. And then we could see slow reperfusion of that contrast through the tissue. Intermittent imaging is another way to reduce microbubble disruption. So a system is gated to transmit and receive data at a predetermined time intervals or is triggered on a specific position of the electrocardiogram. Allows additional microbubbles to enter the field, so there's an even greater increase in reflectivity of the contrast containing vessel or tissue than possible by continuous real-time imaging. Dual display image allows for a high mechanical index imaging on one display and low mechanical real-time data on the other. So clinical applications, there's cerebrovascular applications, peripheral artery applications, renal artery applications, mesenteric and hepatic, endovascular graft evaluation. Cerebrovascular applications permits direct assessment of functional, luminal, and plaque morphology similar to an arteriography and a computed CT angiography. Extracranial 3D is valuable in cases where circular calcifications and severe stenoses, and to improve assessment of ICA plaque morphology. Intracranial contrast enhanced transcranial Doppler significantly improve the number of intracranial vessel segments being evaluated. So Levovis enhanced color Doppler did not show a significant increase in accuracy in distinguishing occlusion or near occlusion over power Doppler. Contrast enhanced can help clarify ultrasound assessment of technically challenging vertebral arteries. Contrast enhanced ultrasound is being investigated for intima media thickness measurements to better define the wall of the carotid artery and determine the blood vessel interface with greater precision. So contrast enhanced ultrasound of carotid dissection. A conventional ultrasound of carotid bulb showing minimal wall thickening. With contrast enhanced ultrasound, the image contrast abruptly stops, producing a rounded leading edge. The hemorrhage from the dissection is anechoic. We have a rounded leading edge, then the dissection here is anechoic. So we can have improved delineation of the carotid lumen and detection of plaque and neovascularization in carotid artery vasovasorum. The left conventional image arrow pointing to an area of plaque. On the right, contrast-specific image with functional lumen and vessel arrowheads within the vasovasorum. So this is harmonic grayscale enhanced carotid enhancement of artery intima media thickness measurements. So unenhanced scan demonstrates slight thickening of the vessel. With contrast, the blood is echogenic compared with the now less echogenic wall. It can be used to enhance our imaging. Can also be used for carotid pseudo-occlusion. So with conventional imaging, it looks like we're getting occlusion of that ICA. So here it looks like the color flow abruptly stops after an endarterectomy. And there's shattering of the CCA-ICA junction. So we get some shattering here. We're not really sure what's going on. And then with contrast enhanced Doppler, we now can appreciate there's actually continuous flow through that area. So it's not actually occluded. The color Doppler shows that the ICA is actually truly patent. So again, it can also be used with transcranial. So that's the contrast agent used is Levelvist. So we can, as you can see on this side with the administration of contrast, we're able to visualize more vessels, get a better assessment of the intracranial vessels. So with peripheral artery applications, atherosclerotic plaque with acoustic shadowings can limit visualization of vessel walls and blood flow detection. Has shown improved detection of blood flow distal to shadowed areas in runoff studies. So severe stenosis can be differentiated from occlusions. Helps provide information regarding blood flow to the limbs, as in reperfusion studies. Particularly helpful to improve visualization of blood flow in the iliac arteries despite overlying bile gas. Can be used to determine the severity of peripheral arterial disease. Can improve detection of perfusion deficits and the degree of arterial collateralization in symptomatic patients with peripheral arterial disease. So this is our traditional image showing an occluded femoral artery that abruptly ends. Occlusion is confirmed after contrast administration. But in this case, we actually can appreciate now collateral vessels feeding into that vessel. So there is some collateral flow that we're able to detect. This is after injection of echogen. So this is a common femoral artery that we perceive that the SFA is occluded. Deep femoral artery also occluded, administer contrast, but we can now appreciate that there is flow getting through that SFA as well as in the profundal artery. Peripheral venous application. So contrast ultrasound is now used often because compression sonography is highly effective in evaluating patients with suspected DVT. So our low extremity duplex exam is very effective. So there really isn't much need for a contrast application. Increased diagnostic accuracy, especially with iliac vein thrombosis. So one area that we could use it would be assessing for the iliac veins, since we can't really compress the iliac veins. Abdomen and retroperitoneal applications, evaluation of aorta, aortic branches, portal venous system, and abdominal organs, used for evaluating renal artery stenosis. Advantages, improves ability to localize and assess blood flow in the main renal artery and the intrarenals. So this could be especially useful if we're not able to visualize that proximal segment. Helps to reduce exam time by allowing better visualization of those arteries. LevelVist has shown to have sensitivity, specificity, and accuracy similar to an angiography. So here we go with the normal renal artery. Normally we don't see anything. Administer contrast, we're now able to visualize aorta. And this is probably the left renal artery coming up to the left kidney here. Again, this is right and left renal arteries after the administration of Echogen. So this patient, we're able to identify actually multiple renal arteries. So for mesenteric application, we can use it to diagnose stenosis and occlusion, especially in the celiac artery and SMA. This study was done with DEFINITY. With hepatic application, it's mostly done to characterize and detect liver lesions. So this is comparable to CT or MRI. We can use contrast to improve detection of hepatic blood flow, detect the presence of portosystemic collaterals, as well as in the assessment and evaluation of tip shunts. So this was, we used contrast in assessing our median arcuate ligament syndrome. So you can see aorta, celiac artery. During expiration, the origin celiac arteries are compressed and displaced inferiorly. So you get a bending of that celiac artery with that deep expiration. We can also use it in patients with organ transplants. A conventional ultrasound is good in evaluating blood flow within the organ, but does not have adequate level of sensitivity to detect tissue perfusion. We can use it to improve assessment of blood flow in the arteries and veins that supply the transplant, the anastomotic host vessel, and the parenchyma of the transplanted organ. We're able to detect ischemic regions within the native and transplanted organs. So this shows a pancreatic transplant, and we see enhancement throughout the entire organ. So it can also be used for aortic graft and stent surveillance. So detecting a fast flowing and slow flowing endoleaks. Provide precise location of the endoleak and differentiate between type 1 or type 2. So A shows a type 1 endoleak. So that's blood flow in the graft and a small area of contrast containing blood flow entering the aneurysmal sac. So just remember back, type 1 is at those connection sites, the proximal and distal connection sites. Type 2 is going to be when we have retrograde flow coming back into that aneurysmal sac from a small vessel. So in this case, it was the lumbar artery, could potentially be the IMA, inferior mesenteric artery. Type 3 would be an actual tear in the graft itself. So emerging applications, evaluation of trauma patients with active bleeding or organ damage, assessment of vascular in and around tendons and joints to identify early signs of inflammatory inflammation and monitor therapy. Optison and Definity are currently marketed in the US and approved for FDA only, approved by FDA only for echocardiography applications. So contrast agents are becoming more popular now, actually, in the clinical setting. And the new KHEP standards, the language is a little vague, but they're starting to, looks like they're going to start requiring sonographers to be certified in IV insertion training. So I know you guys graduate, so it doesn't affect you guys, but maybe going forward, I might have to start incorporating IV insertion. The CVS students do that as part of their training because their Definity is used all the time, right? How often do they use Definity? There you go.
I mean, it's a bubble.
Yeah, it's very common. So they use the Definity and Echo. So they have to actually put in IVs and administer it. New York sonographers don't do IVs. It's actually against the law. So like that's why when I moved here, I was like, "What? You guys have to do IVs? That's crazy!" Like, it's always a nurse that has to put in the IVs. So there's a nurse actually in each echo department that does the Definity pushing and the IV pushing the IV. So yeah, good to hear. So if you're squeamish about IVs, move to New York.
No, think that's fine.
No thanks.
Yeah, no, like, I guess here we just pay one person. I'm pretty sure. Yeah, the raise of that.